Evening, everyone. My name is Peter Schneider. Over this next hour, we're going to cover some cases, which is always the fun part. The concept of this webinar is versatile by design, a case-based look at serration remodeling therapy. I have with me two top experts. One is Dr. Mark Garcia, interventional radiologist, a pioneer in many areas. His work is well known in many parts of the vascular system, interventional radiologist from Delaware, and Dr. John Danks, vascular surgeon from Pennsylvania and northern New Jersey. And each of them are going to talk about serration therapy in their practice, show us a couple cases. So welcome, Mark, and welcome, John.
Thanks, Peter.
Thanks so much.
Thank you.
So just to kick us off, I'm going to talk about serration remodeling therapy, kind of the concepts behind it. And serration remodeling therapy is intended to allow the vessel to return to the extent possible to its native state, in the sense that we would like to create fissures that allow the artery to expand in a controlled manner along a specific line of serration. So if you actually do the math and calculate the physics, the use of a serrating point element to create a sort of a divot or an entry into the arterial wall can be performed at 1,000 times what a POBA can do. The POBA being a flat surface which is expanding its diameter essentially equally in all directions, whereas this is very focalized, using stainless steel strips that are harder than calcium, and this idea to try to create an optimal situation where a terribly diseased artery then can be opened, like I said, in a controlled manner using microfissures. So actually allowing the artery to remodel. And we've looked at this in terms in several different ways. One thing is that there is an interruption of the internal elastic lamina, and this helps to mitigate recoil. We have done a recoil study looking specifically at the tibial arteries, plain balloon angioplasty versus serration angioplasty. And what we found was that the degree of recoil was dramatically reduced with serration angioplasty or serration remodeling therapy versus POBA. And of course, what we're after is outcomes. That is low bailout stent rates, high freedom from major amputation, and freedom from CDTLR. So the serration remodeling therapy, what you see there in the middle panel is an OCT, and you can see actually where the fissure is placed or where the serrating strips have had an effect on the lumen of the vessel and the internal elastic lamina on the far right. You can also see it on IVUS, where this area of the concentric area of disease has been interrupted by serration angioplasty. And this concept, has been, is a little bit different than other vessel prep type concepts, or let's say modified balloon concepts. You have something like a chocolate balloon, which has the pillows essentially of balloon, which are meant to try to harness balloon energy, but then to have the desired effect on a really hard lesion is not so straightforward, not so easy to obtain. With angiosculpt, you have the crossing wires, so with increasing diameter, you have a scissoring of the wires. Both of these devices work, in my opinion. I've used them both. We think that serration remodeling therapy, though, has some specific benefits, and we show you some of those. Shockwave, of course, is another type of modified balloon, and we have other IVLs, or let's say other mechanisms of action to produce IVL, and we'll be seeing that in the coming years. And then we've heard also some discussion about spur and the concept of a point driven into the artery wall, whereas a serration or a Serranator balloon is intended to create a serration with these closely held points at multiple places along the circumference of the balloon. This is sort of a stylized version of what that looks like. We've actually documented microcracks in the calcium using micro CT. And the results, as I said, is what we're really after. So in the Prelude study, 97.7% freedom from CDTLR at 6 months. That was a fem-pop study. The recoil study was a BTK study looking at POBA. Average recoil was 55%, whereas with Serranator it was 6%. And then we also have the low bailout stent rate because we've been able to minimize dissection by doing this remodeling therapy. So that's where we are with Serranator. And honestly, the more fun part is the cases. And so I'm going to stop sharing now, and I will let hopefully there we go. And let's have Mark. Why don't you go ahead and also as you're getting started or before you start, maybe you could tell a little bit about your practice. I know you've done a lot of work in the hospital. You've done a lot of work in the OBL. I've been in your lab. I know the disease, the severity of disease that you treat on a regular basis. Pretty darn impressive. Maybe you could tell a little bit for those listening what your practice is like.
Sure. Thanks, Peter. So I'm a single operator private practice that also provides vascular services to the hospital. I have an OBL that interestingly is attached to the hospital. It's in their medical office building that's attached, which is great because when I get consults or have to do something urgently, I just walk down the steps to the hospital. So it's really nice. It is a lot of inner city, lower economic population. So I have a ton of diabetic, smokers, hyperlipidemia, hypertension, and chronic kidney disease. So we see a ton of not only horrific arterial occlusive disease, but heavily calcified vessels that have been a challenge to treat. Hence, where the Serranator has come into play for my practice.
Very good. Interesting. Okay, what do you got?
All right, this first case is a 66-year-old female with severe chronic diabetic arterial occlusions. She had failed previous SFA and POP recanalization, both endovascularly with stenting, and then failed a fem-BK bypass, in situ bypass. That was done several years prior to this. She was developing worsening rest pain over time, and we had tried to recanalize both the native SFA as well as the fem-pop. That was just an atretic vein from the antegrade approach. So we decided to, in another setting, come back and try from the pedal access. So as I mentioned, the above knee vessels were all occluded except for the profunda, which was a small, smaller than expected size. And it had collaterals to the geniculars, which ultimately, as you can see here, recanalized the anterior tibial at its genu, and then it occluded distally above the ankle. And the both perineal, TP trunk, perineal, and posterior tibials were occluded at their origins through to the bottom of the ankle, where you can see the red is the anterior tibial occlusion. The black is where the perineal gives off the collateral across the ankle to the posterior communicating vessel. And then the posterior tibial was occluded above the ankle. And so I decided to try to go perineal, which we were able to get access. And I did 2 millimeter serration therapy all the way up to the TP trunk. And you can see there's tons of clips here at the TP trunk area. Her bypass came down to just at this area. And this was nothing but just a ton of chronic scarring. And so what I was able to do is actually get up and over the horn. I thought, well, maybe I can get an additional vessel runoff and not only recanalize the occluded perineal for better direct inline flow, but get the perineal open. So came up and over. And so here's an example of the versatility and flexibility of serration. This is a 2 millimeter serration angioplasty from the perineal going up and over into the posterior tibial. And then coming down distally, actually used POBA all the way down to the ankle and up to the mid calf. And from the mid calf up, I used serration. Reason being is I just didn't have great pushability beyond the mid calf to get anything to go down distally. And so this was her result. We got her perineal wide open and into the posterior tibial. And that actually had a good signal in the post recovery area of the posterior tibial down the foot. Her pain resolved. And on Doppler in follow-up, she had both vessels actually still open, in addition to the proximal portion of the anterior tibia, which remained patent. You can see it actually filling here and having some antegrade flow there. So that was the first case.
Okay, that's a really interesting case. So
I thought just to really more than anything show that versatility and flexibility of that balloon going up and over.
yeah, it'd be really interesting to see if she got a bump in her toe pressure or TCPO2 or any kind of indices. You said her symptoms got better.
Yeah, her pain resolved. So she had her rest pain complete resolved, and she actually had very minimal claudication. She was a Rutherford 1 for a period of time, and she's slowly progressing back to getting stuff. This was actually one of our earlier cases of the Serranator.
Yeah.
So, yeah.
And that kind of flexibility to go around that corner with a modified balloon, that's pretty interesting. I don't know that you could do that with whatever, the other tools that are out there. And so if she gets worse again, what'll happen? Will you have to, I mean, she'll need inflow at some point, probably. You kind of got
Yeah.
her over the hump this time.
Yeah,
But
we're gonna. I've talked to one of our vascular buddies, one I work with closely, about trying to recanalize her from above and see what may be possible to get a direct femoral to perineal or tibial bypass done. Unfortunately, she's had a lot of work done in that leg, and so there's a lot of scar tissue there. So I don't think it's going to
yeah,
be.
yeah, and she's not that old yet. I mean, she's still
No.
in her 60s.
Yeah.
So,
Yeah. And otherwise, she looks great. You'd never know it, to see her walking
yeah.
around.
And she has no tissue loss
No, none,
at this
zero.
point. Well, that's good.
Yeah.
Yeah, if she had tissue loss, you definitely would need to get, I'm imagining you would need to get inflow if she had tissue
Yeah.
loss. Yeah,
Yeah.
it's just hard to heal once something gets started. Anyways, very interesting. John, any comments?
No, other than, the thought that probably a bypass. Does she have any vein left at all or no?
Not much. I think he was mentioning maybe trying to get a cadaveric vein to do a bypass with to see if that was an option. So we're talking about what to do next with her.
Yeah, I mean, I think with cadaveric vein, it might actually be worth, just given the propensity of that to occlude quickly, waiting for her symptoms to progress or for her to have tissue loss before you jump to that
Yep.
step, because once you use that, you get it.
Yeah. The 6 and 12 months on a cryopreserved saphenous is not very good. But if she had tissue loss, it might be worthwhile. And she was a
Yeah.
decent operative candidate. Yeah, I agree with you. Anyways, Mark, take it away.
Okay. The second case is a 68-year-old African-American male who had a Rutherford 5 multifactorial PAD, and he came with status post fifth ray amputation for just a foul-smelling gangrenous lesion that got not only started in his toes but went into the metatarsal. So they did a fifth ray amputation. Unfortunately, The amputation was not healing, started to get infected. He was developing severe rest pain, unable to sleep at night. He was developing worsening discoloration and wounds in the toes. He is a dialysis patient. He's got everything else under the sun, as you can see. He had undergone previous to this a very difficult recanalization where his arteries were like drilling through concrete, and ultimately was able to recanalize the SFA and popliteal and establish some inflow, which improved him a little bit, but it wasn't enough to help his wound, his amputation wound, and his progressive changes of his toes. And so initially I could not recanalize the chronically occluded anterior or posterior tibial, but I got a perineal open to the foot. But again, it just wasn't enough to heal him, and we were expecting further limb loss without doing something. And this is what his toe looked like, and you really can't appreciate. You can see some sutures over here, but that was purulent discharge coming really out of this wound still. And then he had a lot of discoloration from the metatarsal head on the first here, and you can see a wound to the nail on the first and the fourth digits. And this was almost looking like it was mummified, becoming mummified almost. So very severe ischemic change. Like I said, he was unable to sleep, just a miserable life he was living. And so I came in from above, and this was his fem-pop, the initial disease. There were stents in here. So in stent, actually pretty rapid in stent narrowing and stenosis that was going on through the popliteal. You can see his non-stented popliteal was severely diseased, getting into the TP trunk, trifurcation, TP trunk, and anterior tibial. And his runoff basically went to the proximal calcaneus, to the top of the ankle and proximal foot. But beyond that, it was really a desert foot. And I had tried coming in antegrade into this anterior tibial to see if I could recanalize that. And the reason being is that you see this little wispy distal anterior tibial into very diseased dorsalis origin, but not much beyond that. But I thought if I could get through that anterior tibial, maybe I could improve that flow. And unfortunately, I was unable to, but as they say, better lucky than good. That little wispy vessel in the dorsalis, I was able to access and get retrograde crossing. And then I used the laser to get some working space, and went in with the 2mm Serranator up from the origin of the DP all the way through the AT, and then used the larger Serranator through the SFA and pop stents. And Lord and behold, we had actually a really great result here. You can see the SFA and pop really opened up pretty nicely. And actually, there's a picture. Well, there's a picture that was missing, I think, but you can see the runoff. We were able to get 2-vessel runoff to the foot. And here you can see that I was able to actually put a 2mm POBA balloon across the DP and inflate and take that sheath out, and got tamponade angioplasty for sealing that off. But you can see now that we have better filling of the pedal vasculature. And this was him actually 2 weeks later. He was healing up pretty nicely. And I just saw him yesterday, and he's got no rest pain. This almost is completely scabbed in. He's got a thin residual opening, but that's all getting scabbed in, and his toes look much better than they did when we started. So for now, we've saved him from getting any worsening, amputation, loss of limb.
Yeah. Good case. And tell me, Mark, when in this particular case, you had it looked like the AT was the key. That, in other words, that the perineal was going to add something, but it looked like the AT was really going to be the primary runoff. And so when you have a case like this, obviously this guy is really right on the edge, because if he gets a deep space infection, his fifth metatarsal is already cut way back, probably. And so in this case, when you have a patient and their only runoff or their main runoff that you're trying to revascularize is AT, what's your algorithm for deciding, oh, is it safe for me to do retrograde access? Um, and I mean, I'll give you my opinion, but I just want to hear like what your thought process and also how you decide, okay, I'm going to put a sheath or not, just stay with a micro puncture type thing for access. What's your algorithm sort of in brief for something
Yeah,
like that?
it really is a case by case. I did not feel that I had a ton to lose here because his DP was so diseased that he was buying, I think, a BTK below the knee amp,
Yeah.
in the near future. And so I didn't think with his AT being occluded essentially almost all the way through, there was a whole lot to lose. I do worry about that. Honestly, the sphincter's a little bit tight when we see those cases. You know that that's the only runoff, and it's just a matter of lots of anticoagulation and vasodilatation medications to try to keep things open as much as possible. I have found myself that working through a 4-pedal sheath is just a lot easier for me than working through a micropuncture catheter. I think I have a little bit more flexibility for devices. And the one thing I hate is when you get stuck sort of now wishing you put the sheath in, and there's really not a whole lot of difference between a 4 or 5 French pedal sheath and a 5 micropuncture. I mean, 4 French micropuncture, you're very, very limited with. So
Yeah.
that's sort of how I think.
And the sheath, so you used a 4 French sheath and you used that to introduce your 2 millimeter Serranator?
I did. It was a 4
Yeah.
French pedal sheath. Yeah, Merit pedal sheath.
And then do you have, just for the audience, when you do a case like that, do you use vasodilators routinely or only selectively? Do you try to get your anticoagulation bumped up in that case of maybe theoretically stagnant flow in a ATDP kind of situation, or do you not worry about that?
No, I worry very much about it. So even though his inflow was really occluded, I still don't want to shut down anything that I if I cannot. And so what typically these patients are oftentimes brought into the hospital the night before they get therapeutic anticoagulation, which does not stop when they get to the angio suite. So it's going all along. We may bump them up with a little bolus if we need to, but otherwise they're therapeutic anticoagulated and just very, very aggressive with the vasodilators. We use nitroglycerin just throughout the case and try to really keep vasodilatation to its maximum as possible, with the help of the anesthesia usually on these cases, because you're going to be in there for some time. So I don't typically do these under moderate sedation, so at least they can help control the blood pressure if it becomes an issue.
Yeah, and these are all really good points. And I'll just say I want to hear what John thinks also, but I'll just say one last thing. One thing I find extremely variable. This guy was a kidney patient. He said he had a chronic renal failure, and I noticed that when I have a patient with ESRD and I put them flat on the table, sometimes they have no pain at all, and sometimes they have terrible pain. And they may even be equally ischemic. And I don't know if it's because of maybe the former patient has more neuropathic damage to their sensory fibers or what it is. But in a case like this, so you mentioned sometimes you get anesthesia help so they can stay comfortable. Do you have any way that you try to gauge that ahead of time? Who's going to have more pain and who's going to? I mean, I always it's a little bit of a puzzle for me, honestly, trying to guess that.
Listen, I don't think there's any magic or algorithm here, except one thing I will tell you about him is when I recanalized his SFA pop, I did it in the OBL, and when I did it, I knew that how he handled sedation and the fact that oftentimes he was a mover. He was a mover and a shaker.
Okay.
So I knew that if I was doing anything below the knee, I was going to get anesthesia. So it really wasn't a question. And that's honestly what happens a lot of times. People come in they get, evaluated in the office and they say, oh yeah, I can do it up here. And, I'm fine with sedation. And you get them on the table and then they're just flailing, non-involuntary movements that you just can't work with. And some of them are like that. And the next time we touch them, we have a no-fly list, and they get put on the no-fly list and they just go to the hospital and get anesthesia next time.
Gotcha. How about John? Any thoughts? Any questions?
Yeah, I mean, so just for me, in terms of whenever I'm getting pedal access or putting in, I use a thin wall, like 5 French Terumo radial sheath. I'm always using a combination of nitro, verapamil, and heparin injected through it as soon as the sheath goes in. And usually I have the patient anticoagulated before I even stick with an ACT of 300, just because I would rather have bleeding issues than clotting issues. Always, especially if I'm in the foot. I mean, those are sort of my just go to what I do all the time.
Yeah, makes sense. And John, just remind us, you're more in outpatient, more in the hospital, or both?
So I'm at a hospital employed situation at a very much inner city, really bad diabetes, really bad end-stage renal disease. I mean, these are patients with poor access to care, poor follow-up, it just really, really in bad shape.
Wow. Okay.
Calcified, everything's occluded, everything's below the knee. Everyone's getting general anesthesia if their heart can tolerate it because I know it's going to be a big project. It's sort of almost a joke. I shoot a picture and everybody in the room goes, oh, this is a diagnostic case. And except everything's occluded.
Yeah. Yeah.
I just take it one vessel at a time. And once I reach sort of the 2 hour mark, I'm like, okay, I know I have to open another vessel, but like, we're not going to stand here for 6 hours today. So, I do all the work that I can do, try and get my inflow, my outflow on one. And then, if I need to, come back another day.
Yeah. Okay. All right, Mark.
Yeah, last case is a 67-year-old female who came with critical limb ischemia. She was an RC5, worsening rest pain, ischemic wounds to not only her foot, but the Achilles. And interestingly, vascular surgery, she came from another hospital, recommended to do an above the knee amputation a year prior to this, after they had failed attempts at revascularization, heavily diseased calcified vessels. And so the daughter, who knew me in a roundabout way, had her transferred, and we actually opened up her left leg, and that to this day has been fine. This was her contralateral leg that she presented with. We had recanalized that leg after the left leg a year prior, also in June of 2025. But she presented to the office several weeks ago with recurrent ischemic wounds. She had an occluded SFA and popliteal stents with no signals in her tibial. Her ABI was 0. And so we took her originally, and this was what we found. She had severe, so this is the groin here, this is the external coming down. She had severe stenosis of the common femoral. This was what we had of a profunda, small little tiny branch with a severe medial stenosis here. And basically her SFA and pop stents were essentially, occluded. And selectively, when we got down into the popliteal distally, we saw a trifurcation stenosis. TP trunk was diseased into a perineal, and the posterior tibial was occluded, anterior tibial was occluded. So looking down further, basically the ankle was down here. So this perineal came to several centimeters above the ankle and just petered out, and basically no flow in that foot, which is why she was in such strenuous losing that foot. So from an integrated approach, did a 8mm Serranator to get that common femoral open, and then the 6mm through the SFA and popliteal to try to just improve flow, then to work on the tibials. And that was successful. We got actually really good result in the SFA and pop. And usually with these in-stent restenoses, I Serranate, and then I use, it's sort of actually that remodeling therapy where I'll balloon with the Serranator and then use the DEB to coat that in-stent stenosis and hopefully prevent it from the quick recurrence. And so we got the SFA and popliteal open, and you can see her foot, the perineal runoff didn't really improve at all with that improved inflow. It still remained a desert foot. Basically, I successfully got into the perineal first, and we did serration angioplasty with a 2.5 through the TP trunk and perineal all the way down. And then again, better lucky than good, I was able to find the anterior tibial and work my way down into the DP and serenaded that vessel. And here we are with the runoff, basically SFA pop. You can see we got a really nice 2-vessel runoff down into the foot. And you can see the DP sort of just stopped at this point, very small little collaterals, but at least we've got some flow now going into the foot. And ultimately, after doing a little work and an additional 2mm angioplasty of that DP, we got, this was the initial and the final pedal perfusion. And she actually got discharged back home with that foot remaining remarkably perfused and doing much better.
Wow. So the flow into the DP was primarily through perineal?
No, we got direct access into it. This was actually her anterior tibial into the DP.
Yeah.
And then we were able to cross this with a POBA and just dilate that up. And that was the final result we got here, was flow that came in and gave me a much better sort of collateral pathways into the metatarsals, and you can see the plantar filling better and so on.
Yeah. Well, I gotta say, you started out with a really ugly angio.
Yeah.
A lot of disease there. And tell me, in this case, did she get, or you might not have gotten that far yet, did she get a bump in her hemodynamics?
I'm sorry, you mean
Like a toe pressure or,
we
something?
haven't gotten there yet. She hasn't had any
Yeah.
follow-up yet because this was literally just a couple weeks ago.
Yeah. Well, that's a really nice case. I mean, I hope she heals with that. And you mentioned that she has an Achilles wound also, so you
Yep.
may end up having to do more.
That's
But
probably
what
gonna
you
be
got
debrided.
looks so good compared to
Yeah.
what you started with.
Yeah, interestingly, when she stayed in the hospital for several days, and when we were evaluating her in follow-up, amazingly, her DP had a bounding 2+ Doppler, and actually her PT came back. And
Huh.
so I don't know if it was coming retrograde or antegrade, or if there was a collateral from the perineal ultimately, but she had a solid signal in that foot just at the Achilles where that wound was. So she may actually get a little bit of debridement and heal. We'll
Yeah.
see.
Yeah, it'll be fun to see, like I said, what the hemodynamics show and how she does.
Yeah.
I mean, sometimes when I have a patient like this that essentially starts out, I mean, your initial angio essentially looks like a desert foot. And when you see the perineal, you're one inline flow and it just cuts off like that. That's usually a horrible situation. Do you ever, in a situation like this, follow up with any kind of, intravenous, like IV therapy of heparin or anything else? Or do you just say, okay, we're just going to go to our dual antiplatelet and we'll just see what happens? I mean,
No,
I'm tempted sometimes, but I don't end up doing it because everybody's so anxious to get things moving. But
yeah, to be honest with you, I've become very aggressive with anticoagulation and antiplatelet therapy on these patients. Especially people like this, I'll put them on full dose anticoagulation. She's on Eliquis 5 plus Plavix. And,
okay.
we talked to the family about the opportunity to do that and try to keep it alive versus, having an amputation. And actually, she was prepared for the amputation. I told her that I'm not sure that we're going to get her foot open when we did the initial angiogram. And I told him, fingers crossed, lots of prayers, but we weren't really sure. And then we ended up getting this result.
Yeah. So far, so good. John, anything Any questions?
Yeah, I've noticed in our practice, we tend to have a lot of resistance to Plavix, so we're checking P2Y12s in people regularly. And for anyone that's over 180, we're switching typically to purulent. And doing that pretty aggressively, especially for all of this uh, tibial severe disease. Everything's calcified. There's not good runoff, and if it doesn't work, they lose their leg. I'm pretty aggressive with that.
Yeah. The other thing I've come accustomed to using in people who don't have a history of cardiac or CHF is clopidogrel also, adding that onto the therapy.
Yeah, and we're going to go to John's cases, but let me just say there's a question in the Q&A box, and this is for Mark. You had successfully treated this patient, but she presented with recurrent ischemia. Do you see Serranator preventing restenosis differently than your prior approach, or is recurrent disease in this high-risk population inevitable? What do you think?
I honestly think it's the latter. I think it's inevitable. They're so far diseased. Their arteries are rock hard. And the idea of the surgical bypasses. I know you guys do a lot more than you used to do, but I've also heard from my colleagues of the friends that I work with that it's not an easy chore to try to dissect down into these very heavily, 360 circumferential calcified vessels. So I think it's just part of the disease, the nature of the disease, and ultimately they're going to come back, and we try to follow them closely and prevent this from happening. She was actually seen in the office 2 weeks before this, and she had signals, and she shut down that quickly. So it's just part of what we see.
Okay. All right. So, John, you want to, or maybe Mark, you could stop sharing.
Yep. Sorry. Okay.
You guys see everything?
Yes.
Okay, so again, my name's John Danks. I'm a vascular surgeon. I've been at St. Joseph's University Medical Center in Paterson, Wayne, New Jersey for the last 8 years. Paterson is just very, again, inner city, like I talked about. A lot of smokers, but also just a lot of very uncontrolled diabetes and just a gigantic population of end-stage renal disease patients on hemodialysis. So I'm going to talk about 2 cases today. The first case is actually a patient well known to me. She's a 46-year-old Hispanic female with severe chronic uncontrolled diabetes who's been following for a long time. She has had multiple different bouts of severe diabetic ulcers and just other non-healing wounds and ulcerations of both legs, but particularly her left lower extremity, despite following up with us regularly. And by the way, she's also had multi-level disease, SFA occlusions, stents into her SFA, occlusions of all tibials, etc. She actually came to see us in clinic this past Friday, and this case got done yesterday. And she, on her duplex, had a pretty significant stenosis of her SFA, but more importantly, she had a rest pain of her left foot with a new small area of gangrene at the tip of her left great toe. So just knowing her history and how she occludes everything, and given how her duplex looked, I made the decision that we were just going to take her for angiography. As you can see, she has stents more proximally that did have disease that was treated, but just sort of focusing on where her main lesion was. So we're looking at the popliteal artery. There's a high takeoff of the anterior tibial artery from the popliteal artery. And then obviously just complete and total occlusion here with no real perineal or posterior tibial artery. And this is just the angiogram of the same picture, just showing you the collaterals and just the anterior tibial artery. So moving on, this was distally what reconstituted. So the anterior tibial artery occluded and then came back with this small sliver here into this dorsalis pedis artery. And then this, of course, a reconstitution of the perineal artery, and no sign of the posterior tibial artery or any of the lateral or medial plantar arteries. And this is just an angiogram of that same situation that we were dealing with. So just frankly, from the starting picture, and it looked like it was going to be easier to get into the anterior tibial artery via an antegrade approach versus trying to get into the perineal. I made the decision to come antegrade and cross into the anterior tibial artery. Laser atherectomy and then 3 millimeter balloon angioplasty was done of the dorsalis pedis, the entire anterior tibial, as well as the popliteal artery. And distally, I know this is not a perfect picture. I was catheter occlusive up top, which is why I ended up with this angiogram looking the way that it was. But we got inline flow through the anterior tibial artery into the dorsalis pedis artery. And this looked pretty nice. We IVUS, I'm a big fan of IVUS. I also think IVUS is particularly nice in terms of deciding, especially if you're using, a device like a Serranator balloon, to really pick what the right size is. That way, you're not undersizing it, you're not oversizing it. I think it maximizes your results while also decreasing your risk of complications. So anyways, this is after laser atherectomy and the 3 millimeter balloon angioplasty. And this is actually IVUSing this area from the popliteal into the anterior tibial artery. So at this point, distally, it was in a better situation now with inline flow to the foot. But obviously, there was still pretty significant disease of this anterior tibial artery and popliteal artery. And after Serranator therapy, the AT now looked like this. So again, we were in this situation, the same vessel, same exact place, to this after Serranator balloon
It looks
angioplasty.
particularly good. Yeah.
It looked pretty. I was very, very pleasantly surprised when I
It's
saw
hard to
this.
make a severely diseased proximal AAT look good very often. I mean, and maybe this is a little different because it's a high takeoff, but the standard AT anatomy where that proximal 2-3 centimeters just prior to the upgoing, collateral before the genu, that's a hard area to treat and have it look good, where it's passing through the interosseous, et cetera. Anyways, this looks good.
Yeah, I really I prescribe to Mark's philosophy of it's better to be lucky than good always, 100% of the time. So
No argument.
this is what the final picture of the AT. I went on to treat this popliteal more, but this is what that AT looked like after the serration therapy. And then, so interestingly, I thought this was useful and particularly instructive for me, just because I do a lot of IVUS. So on the top left image, this image here, this is after laser atherectomy and 3 millimeter balloon angioplasty in the anterior tibial artery, where even after all that, you can see the calcifications that are here. There's still a 64.7% stenosis on intravascular ultrasound. But literally looking at that same exact point, because we looked at it angiographically and with IVUS to make sure we were looking at the same spot. After using the Serranator balloon, the stenosis was reduced from, again, 64.7 down to 27.4%. So, I mean, if you're thinking laser and then HOBA and you still have a residual 64% stenosis, and then you use, one insufflation of the Serranator balloon and you're dropping that down to 27.4%. I mean, to me, that's just really significant in terms of luminal gain, how it's modifying the rest of the vessel, what it's doing to the calcium, et cetera, and then just overall increase in the flow to the foot. When this patient was done, she had a palpable dorsalis pedis pulse. Honestly, she had some reperfusion pain, et cetera. Obviously, I don't have any follow-up because I did her yesterday as an outpatient and sent her home. But really happy with the result here, and also think that, you know, being able to see what the Serranator is doing sort of more from a 3D perspective by having the IVIS is it's just sort of a nice addition, right? You're not just seeing the 2D angiography, you're really seeing this dramatic change in the lumen of the vest.
Yeah. And also I think whereas I mean, you become a big IVUS user after you realize that the angio totally underestimates the degree of disease. It didn't look that bad on the angio, and yet the IVUS calculated 64.7%, so pretty significant stenosis. The other thing I'll just mention briefly, and I think Mark and I have discussed this before, but when you look at core lab adjudicated studies of BTK balloon angioplasty, what you find is that that a residual stenosis of 30% or more is super common. Again, if you look for the ones that are core lab adjudicated. But in my practice, since I always get a perfect result, there's never any residual stenosis. But I'll just say, no, I don't know, Mark, any comments on this case? Do you use IVUS much? What's your
Yeah, no,
algorithm?
I get amazed at the difference between angiography and IVUS. I mean, it's to the point that you really wonder what the hell we're looking at on angiography, sometimes. But it's a great case, and it just goes to show what some of the effect of what the Serranator can do in getting luminal gain. The part that I wish I really truly understood a little bit better was the patients that you've got to come back and do something more in the foot sooner than later, versus those that will, with that increased flow, will actually, I'll call it, propagate some vasculature and improve perfusion over a little bit of time. There are people who, once you get one vessel in line, you do a follow-up and they've got a whole lot more vascularity in 2 weeks, 2 weeks later, whereas some people, they just don't, and they start to shut down, and you wish you kind of went in there sooner to try to get some more. And I that part is still a conundrum to me, trying to figure that out.
Yeah. Yeah, it's
So
interesting, isn't it? Almost like as if in the patients that have that really diffuse, profound vasculopathy, they don't restore any pulsatility. They, maybe you have a signal at the target, but then the runoff doesn't really light up the foot. Anyway, John.
yeah, I guess in my experience with that, a lot of the times patients with other comorbidities, including hypertension, diabetes, et cetera, that are just really poorly controlled, are the patients that tend to shut everything down repeatedly, no matter what you do. I've also found that actually younger patients, so patients that are 30, 40, and then obviously much older patients in their late 80s and 90s, both of those patient populations, if they have severe disease, are much less likely to open things up. Where I feel like if I have a 60 or 70-year-old patient whose comorbidities are better controlled, their diabetes is controlled, they're a lot more likely, once I open something, to start opening up the other vessels in their foot. So I really think that other medical management piece, good follow-up, controlling the comorbidities is super important, makes a big difference.
Very good. I think we have time for one more case. John,
Sounds good. Yes. So this patient, this is a 77-year-old Caucasian male who actually had seen me 2 years prior and came in such bad shape that his limb was just not salvageable, and he ended up with a left-sided below knee amputation. He actually developed gangrene of his right heel and went to an outside hospital sent by his podiatrist, where they performed a diagnostic angiogram, and only a diagnostic angiogram, and told him there was nothing he could do. And somehow or other, he made his way over to me, got admitted, and this is what his initial tibial shot looked like. Obviously, very severe disease of the proximal anterior tibial artery. There's this tibial peroneal trunk looking vessel that's here, and then no real visible peroneal or posterior tibial artery. And then this is the angiography shot. So again, in this patient, he has a heel wound. So it looks like my best option is the AT, which I end up going for just because the PT doesn't come back, which you're going to see in a moment. But this is what the reconstitution looked like. So the AT came back. There was this DP, some pedal arch, and then the lateral plantar artery here looked occluded. The perineal did come back and maybe was filling the heel some, but just no evidence of any sort of reconstitution of the posterior tibial artery. Again, this is just the angiographic picture of this. So you can see what the flow looks like some. So I tried to come from above and it just wasn't happening at all. So I ended up retrograde sticking his very distal anterior tibial artery and came up with 014 wiring catheter. Ended up having a little bit of a battle, but between ballooning from above, ballooning from below, ended up crossing and getting an 014 wiring catheter down into the foot. And actually around the pedal arch and into the lateral plantar artery. This patient got a laser atherectomy and then balloon angioplasty of the lateral plantar artery, the pedal arch, the dorsalis pedis artery, and then the entire rest of the anterior tibial artery and into the popliteal artery. Subsequently, because of the just very severe calcified disease, even though I knew I was going to use Serranator, I actually frequently will use shockwave lithotripsy first in these like very, very severely diseased patients. So he got shockwave lithotripsy of his, DP, the entire AT, and up into the pop. And so after POBA laser and shockwave lithotripsy, this is what the AT looked like. I was actually really happy with the distal flow here. There was now inline flow into the AT DP with filling of the pedal arch, and also some filling of the lateral plantar that was almost making its way toward the heel, which I was happy about. And then this is what the flow looked like. And so this is before Serranator. After Serranator, so I used a 4mm Serranator balloon, obviously after ivasing in the proximal portion of the anterior tibial artery and then up into the popliteal artery. And this was the post result, which honestly was just markedly better. So with really good flow down the AT, the ostium initially had a pretty significant lesion that looked much better. And then after all of this was open, the flow through the AT into the DP and around the pedal arch, filling that lateral plantar, even looked better. And that's what the angiogram looked like at the end. He also had a palpable DP pulse and a nice, good biphasic, I'm not really sure how, but a PT signal. And then, so again, just demonstrating what this looks like on intravascular ultrasound, as Peter said, you're almost always going to have some amount of residual stenosis. I sometimes see other operators that function in my hospital that they're saying was 90 down to 0% stenosis or 10% stenosis, and I want to be like, I don't know what these people are doing. Maybe I'm doing something wrong, but on IVIS, that's just never the case for me. But nevertheless, this patient, after shockwave, POBA, and laser, still had this residual 70.7% stenosis in that proximal AT. And then after the Serranator, that was reduced to a 56.7% stenosis. So I guess just making the point that even after using multiple other modalities, moving on to the Serranator balloon produced not only a better angiographic result of that proximal AT, but better filling in with the foot and a significant reduction in this residual stenosis as demonstrated on IVUS here.
Do you think, what do you think the chances are that it'll heal up the heel gangrene?
I mean, I'm going to have to see what happens. He's going to get a debridement, etc. I'm going to give him some time and see how he does. Like check his ABIs, PVR, see what's going on. I'm talking to the podiatrist after they do the debridement to see how does it bleed, etc. And then, I mean, there's always the option to further revascularize the perineal, and I'm hoping that maybe something comes back. This is one of those situations where I'm like, I'll give it a couple weeks, and maybe he'll give me some sort of posterior tibial artery that I can actually revascularize.
Yeah, and maybe, and you said there was a signal, so I mean, it's probably coming through the arch, but it means there's at least something. There's a target there if you have to do more.
Yeah. I mean, this sort of situation where I end up going around the arch, like from the AT into the lateral plantar in order to get blood flow to the heel is something I do routinely when I just don't have other options. And it's worked in the past.
And if you don't see a posterior tibial from above coming down, you could always try to get that additional flow via the perineal retrograde and try to, if you can't find it from above, it's retrograde. We can't. It did have a posterior communicating to that heel, it looked like, if I saw it correctly. So that may be enough to heal him up, heal the heel.
Yeah, opening the perineal is my next step.
Yeah, very interesting. And so just, we got just a couple minutes here, but let me just ask, so just so I understand, back to the IVUS. So John, do you use it on every case, most cases, more than half the cases? What would you say?
If I intervene, I IVUS every time.
Okay. Good to know. How about you, Mark? What's your algorithm or kind of general usage?
I will tell you that I would say in the OBL, probably 3/4 of the time or so. I use it particularly for tibial, so I can size it more so. But in the hospital, we have an old machine, and it's really cumbersome and a pain. So I use it more, I would say, less frequently, and really when I have trouble and I got to just figure out what the hell's going on.
Yeah. The other thing about all these cases is almost every case had a tibial component, and we saw Mark go up and over perineal into post tib, and we saw also going into the foot with the Serranator, and that's not necessarily that I would advocate going in the foot if you don't have to, but if you have to, it's nice to have a tool that will cross the ankle that you can rely on, that hopefully gives less chance of a bailout than a plain balloon, and with any with good luck, a hopefully better lumen as well. So anyways, I think we're at about an hour now. I don't know how all that time went by, but it's always fun looking at cases. That's the main thing. And also to have two experts such as yourselves to share it with us. So really appreciate that. And I'll call a close to the hour. Any final thoughts, Mark or John? Take the rest of the day off. What's for dinner? Oh, now you can finish your electronic medical records. Now you have plenty of time for that. Okay.
That's right.
Anyways, good to see you guys, and thanks so much for your contributions and really for educating me and for give everybody a chance to get a look at your practice. So thanks.
Thanks, Peter.
Thanks so
We
much.
appreciate it. Take care.
Bye-bye.
Take care.
Bye.